Hi doctors, how are you? Hopefully you did enjoy the first practical part of our course, which was restorative dentistry in this week. Moreover, in this week, because we would like to condense our schedule, not to give you more material in January, we're going to discuss also about pedodontics or pediatric dentistry. It's not that hard, it's related to restorative dentistry, but in these chapters, I'm going to be more specific for the primary teeth, the difference in the management, the difference in treatment, and little bit difference in the vital treatment, non-vital treatment. And the most annoying part is the part I'm going to discover it now or cover it now, which is embryology. Yes, it's annoying, I know. I will try my best to make it as much as I could to be smooth and to the point. I will be super selective when I'm trying to explain about it, and I will do it two way. First way is the story way. I will tell you a story about it, will get you to be somehow curious about the answer for the problem, and then at the end, let's discard the story part and give you whatever you really need to memorize. I would give you my humble advice, just listen to the story part just once today, and later when you study, go to the part where you just need to memorize. Don't listen to story again. It will be boring, I think. Okay, let's start with our question and get rid of this annoying part in pediatric dentistry. Okay, so what's the meaning of embryology? It's a science dealing with the formation and development, structure, and functional activity of the embryo. It's a big story. We don't need to care about it. We are going to care only about the head and neck development and the oral cavity. So differentiation occur in the third week and involve epiplast, which is part of the development of the embryo, to come into the laminar disc, which is ectoderm, mesoderm, endoderm. So ectoderm, mesoderm, endoderm, first it appear at the third week. It also involved the mesoderm spreading to form the noctuchord, and then the process of gastrulation taking place. At the fourth week, involve neurulation, which is formation of the neural tube, segmentation, organization of somatis, and folding. Yes, it's getting dull. Okay, so let's go back to explain about this word I did say. So gastrulation is a critical phase in the early embryonic development that occur in the third week. During this process, a single layered bastula, which is this one, epiplast, recognized into trilaminar, which is ecto, meso, and endoderm. Okay? A structure known as the embryonic disc, forming three primary germ layers. These layers give rise to all tissue and organ in our body. So this is how it goes. I'm going to discuss only from here, day 12, and this will lead us to this embryo at the fifth week, and then we're going to zoom in over it to see what's really happening here. So here we said it will be differentiated into endoderm, mesoderm, ectoderm. I think from the name, endo mean like inside. This will come to be like the lining of the organ. Mesoderm will come to give that muscle, and ectoderm will be the cover ending on by skin. For sure, this is to cut it in very simple term, but this is how usually the process is going to be. The branchial arch are embryonic structure that develop into the anatomic structure in the adult human. The term branchial derives from the Latin, which is branchia, meaning gills, and is used to describe the development of many species of fish and amphibia. Because we are not fish, we are going to replace this branchial arch into the pharyngeal arch. So what's the meaning of pharyngeal arch? So these three type of cells with ectoderm, mesoderm, endoderm, it will form arches. These arches will come into place, and these arches will be responsible to get the face, get the everything inside this area. So you see this arch, it will become first, second, third, fourth, and fifth and sixth arch, and the fifth arch will involute while the process is going to develop, and then it will give us this final shape. Okay, so as you can see the color here, it will represent how it will end at the end. So I will try my best to explain it as a story. At the end, I will give you one slide with all the information that you need to memorize. Okay, so let's go back to the pharyngeal arch. To more accurately describe human anatomy, the branchial arch or pharyngeal arch gave rise to the lower face, neck, and part of the upper thorax, which up till here, while the frontonasal prominence gave rise to the forehead and the nose. The other structure formed by the branchial arch are the result of contribution from the primary germ layer, which is ectoderm, mesoderm, and endoderm, plus the neural crystal derivatives. So these three come into action with the neural crystals to give us some neural cells. This neural cell will give the sensation for all the structure coming from such such ectoderm, mesoderm, and endoderm. Failure of the branchial arch to correctly develop result in anatomical and developmental defect manifesting in many ways that will be detailed further below. Branchial muscle are derived from the 5 branchial arches contained within 4 pharyngeal pouch. So, oh my goodness, branchial arch pouch, like Cliff, this is too much. Okay, so let's move on to this picture to discuss about this one. So we said we have the arch. So this is the arch, okay? The arch, as we said, from outside, it has what we call from outside ectoderm, okay? And from inside, we have endoderm. So the layer inside, when we look from inside, the junction between the first, second, third, and fourth pharyngeal arch, the junction from inside is covered by endoderm, and we are going to call it endoderm pouch. And the junction between two arches from the outside is covered by ectoderm, and we are going to call it ectoderm cleft. So the ectoderm cleft is coming from outside, as you can see here, and we're zooming in here. And the endodermal pouch is coming from inside. And the arch itself, it have mesenchymal cell. This mesenchyme will give us the skeletal muscle and cranial nerve and some main artery in our body. And here a different way. So cleft coming from ectoderm outside, pouch come from endoderm inside, and mesoderm in between both. We have 1, 2, 3, 4, and here 5 is going to be convoluted, like it doesn't form or regress, and then the 6 is coming here. So the structure coming from the first 4 pharyngeal arch are important, specifically 1 and 2, because 1 is called the mandibular arch, and the second one is called the hyoid arch. Okay, so let's see now the English wording, how we describe it in English. Okay. So we have this pouch. These pouch emerge in the 4th week of embryo development and give rise to structure of the head and neck and face. Each pharyngeal arch consists of mesodermal cell, which is going the branchial muscle, with an embedded nerve, artery, and skeletal elements, as we discussed in the previous slide. The mesoderm mesenchyme is surrounded by outer ectoderm layer and an inner endoderm layer. The bird pharyngeal pouch surrounded the pharyngeal gut. Okay, so all the pharyngeal pouch in this area is surrounding this, which we call pharyngeal gut. So again, I would like you to understand this is how it look, and this is how it look when you look from up here. Okay, the branchial arch that develop in human include arches from 1 through 6. Branchial arch number 5, involute, which mean like disintegrate or like disappear during the development and does not contribute to the formation of other structure. Branchial arch 1 and 2 are referred to the mandibular, so 1 is mandibular, and the hyoid arch, which is number 2. Mandibular 1, hyoid number 2. Each of the arch is lined internally by endoderm and externally by ectoderm, except the first pharyngeal arch, which is covered entirely by ectoderm. So here, when we speak about the first pharyngeal arch, here it has ectoderm and here it has ectoderm. But it still has the endodermal pouch, not the endoderm, the first pharyngeal arch pouch and first pharyngeal arch cleft from the other side. Okay, the pharyngeal cleft, which we said is coming from ectoderm and the outer side, are produced from the approximation of ectodermal tissue between consecutive arch, while the pouch come from constitutive arch coming from endodermal from the inside. So I keep repeating the same information in a different way just to make sure you catch it. And here, the summary. Pharyngeal cleft, anatomical space formed by first pharyngeal cleft between the first and second branchial arch give rise to adult external auditory meatus. For our good luck, the space created by second, third, fourth pharyngeal cleft give rise to adult cervical sinus, which is as a dentist, so you don't care about it. So the first cleft, which is coming from first and second pharyngeal arch, giving the adult external auditory meatus. How about the pouch? Pharyngeal pouch. The first pharyngeal pouch between the first and second branchial arch give rise to primitive tympanic cavity auditory tube. The second one will give us the adult palatine tonsil. The third one will give us inferior parathyroid gland. And the fourth one is giving us superior parathyroid gland. So this is the main character or the main structure coming from these. Again, at the end, I will give you summary for everything. Okay, moving forward, we have endoderm. We said this endoderm branchial arch develop into the endocrine viscera from inside. And we have mesoderm, which is in the middle part. This middle part will give us the vasculature and musculature structure. Musculature meaning the muscle, muscle of facial expression, muscle of mastication, and vasculature mean is the vessels coming from each phalangeal arch. Ectoderm, we said like this ectoderm from outside. Ectoderm derivative can be divided into medial and lateral domain. So the ectoderm itself, it has one part which is facing inside. This is the medial part, and one which is facing outside. This is the lateral domain. The medial domain of the neural ectoderm give rise to the nervous system derivatives, while the lateral give rise to the skin. I think this makes sense. So skin, nerve, muscle, vessels, and then in line, which is endoderm, to give us the lining of all the organ inside. The neural ectoderm generate NCC, which is the neural crest cells. Neural ectoderm, which is this one, the medial part of the ectoderm, generate neural crest cells, NCC, that migrate to either the frontonasal prominence or branchial arch to give rise to the bone of the jaw, skull, ear, as well as cartilage found in the head and the neck. The peripheral nervous system itself derived from the dual origin of the surface ectoderm and the neural crystals. So in short, this ectoderm will be attacked by cells of nervous system. This cells of nervous system in part will give us the cranial nerves, which we're going to discuss like simply here, and when we go to anatomy, we're going to discuss in depth, or is going to give us the innervation where it comes to the bone of the skull, jaw, cartilage found in head and neck. Okay, so if you are like, you don't like the story, you don't like this too much, so you have these two slides which you need to memorize. These two slides where you need to memorize it, because easy peasy, sometime asking you some question about like this component coming from which pharyngeal arch, this component coming from the groove or coming from the pouch or coming from the arch, this component coming from the arch, which is correct or not correct. So sadly, I'm saying it out loud, sadly, you need to know it. And I did write it down if you don't like, because I know some people don't like this diagram, so I write it in simple term. So first, branchial arch, we have cleft, which is outside, it's giving us external auditory canal or external auditory meatus. Arch itself will give us mandible, ancus, malleus, a muscle of mastication, and cranial nerve, which is trigeminal V2 and V3. So we have in trigeminal, we have ophthalmic, and then we have maxillary, and then we have mandibular. So this is V2, V3. So V2 and V3 of trigeminal is coming from the first pharyngeal arch. The pouch is going to give us Eustachian tube, mastoid air cell, and maxillary nerve and mandibular branches coming from trigeminal, so which is cranial nerve V2 and V3. So this is coming from the first pharyngeal arch. Second pharyngeal arch, we said the cleft is giving us cervical sinus from the second till the end, so we don't care about that. The arch itself will give us stapes, the body of the hyoid, lesser horn of the hyoid, muscle of facial expression, and cranial nerve number 7, which is the facial nerve. The pouch will give us the palatine tonsil. So the palatine tonsil, the pouch which is inside, and the arch outside is related to the structure coming to the bone, which is stapes, body of the hyoid, lesser horn of the hyoid, muscle of facial expression, and the nerve here is the facial nerve. So I hope the story we still in the beginning makes sense now, because we said the endo, which is like endoderm inside, is coming to give us the pouch, which is coming to the inside. And the ectoderm, we said the lateral ectoderm is invaded by the nerve, which giving us the cranial nerves and give us the bone. The third one, arch itself, is giving us the body of the hyoid, greater horn of the hyoid, superior constrictor muscle, and internal carotid artery. Pouch, thymus, piriform recessus, inferior parathyroid gland, and the nerve here is glossopharyngeal nerve, which is cranial nerve number 9. Please, I write it here, not write it 9, because sometimes he will ask you which of the following cranial nerve coming from the third pharyngeal arch, and giving you this symbol, giving you this symbol, giving you this symbol. So please, please don't lose question because you don't know what's meaning of such symbols. The fourth branchial arch, giving us the arch itself, is going to give us thyroid cartilage, cranial nerve number 10, which is the vagus nerve, aortic arch, right subclavian artery, various laryngeal muscle. The pouch will give us superior parathyroid gland, and the nerve give us the vagus and superior laryngeal nerve. Fifth and sixth branchial arch, cleft nothing arch will give us the inferior parapharyngeal constrictor, the cranial nerve, which is related to cranial nerve number 10 and number 11, and various laryngeal muscle. Pouch, parafollicular cell of the thyroid gland, and vagus nerve number 10, and recurrent laryngeal nerve, and vagus nerve number 10. I remember in one cycle they asked about this vagus nerve. So it's unfair because like you let everything related to us as a dentist and you're asking me about the last one. So I hope the story is like going so far easy in a way, and the part you need to memorize, which is this part, okay? Let's go different story. I think this story is really interesting. So the story of the tooth life cycle. So the tooth life cycle starts by initiating, go to the bud stage, cap stage, pill stage, root formation. How we are going to discover this story? I'm going to tell you each stage, when it will happen, what is going to happen, and what error will lead. If error happen in this stage, it will lead to which defect you will see. So after listening to this, you will know big shape lateral coming from which, amesions and imperfecta coming from which, detusions and imperfecta coming from which stage. Again, at the end, I have 2-3 slides to give you the information where you memorize. If you want to skip to this part, yes, feel free to skip like the previous one, but I would encourage you at least once to hear the story. So initiation, evidence of development of human tooth can be observed as early in the 6th week of embryonic life. 6th week, and this was a question from previous cycles. Cells in the basal layer of the oral epithelium proliferate at a more rapid rate than do the adjacent cell. The result is epithelial thickening, as you can see here. So this epithelial thickening, which we call initiation, this initiation happened in the 6th week of embryonic life. The result is epithelial thickening in the region of the future dental arch that extend along the entire free margin of the jaw. This thickening is called the premordium of the ectodermal portion of the teeth, and what's result is called the dental lamina. So in the initiation, it happened here, but like later, we're going to call this the dental lamina. At the same time, there is 10 round or ovoid swelling occur in each jaw. For this 10 is representing what we call later the primary teeth. So we have 10 start to appear, which is going to be later the primary teeth. 10 in each side. Certain cells of the basal cell region to proliferate at a more rapid rate than do the adjacent cells. So here, this is the way it had end up by the thickening. These proliferation cells contain the entire growth potential of the teeth. The permanent molar, like the primary teeth, arise from the dental lamina. The permanent incisor, canine, and premolar develop from the bud of their primary predecessor. So you remember this this 10 round. So this 10 round will give us the rise for the primary teeth, and later it will give us the rise for the permanent coming from this tooth bud. How about the permanent with no predecessor? It will come later, where it have this tooth bud, and this tooth bud will give us the permanent teeth which come without primary teeth, like 6 and 7 and 8. Nice. The congenital absence of a tooth is the result of lack of initiation or an arrest in proliferation of the cell, and the presence of supernumerary teeth is the result of continued budding of the enamel organ. So, at the initiation stage, if I'm asking you a question, error at which stage will lead to congenital absence? So it will be initiation. Extra initiation or extra bud stage, at which stage will give us like supernumerary teeth? So again, it's in initiation. So this is how we're going to conduct each stage, explain what's really happened, what error will lead to which condition. Proliferation. Proliferation of the cell continues during the cap stage. So what's the meaning of cap stage? So you remember this thickening, so it has a relative increase in the proliferation in this area. So this will end up by moving down. So will give us what we call cap stage. This cap stage. Okay, this cap stage. Okay, proliferation of the cell continue during the cap stage as a result of unequal growth in the different part of the bud. So this bud will come to be a cap is formed. A shallow invagination appear on the deep surface of the bud. Here, shallow invagination coming here. A shallow invagination appear. The peripheral cell of the cap later form the outer and inner enamel epithelium. So outer and inner enamel epithelium is coming at this stage from the peripheral cell, H cap stage. As with a deficiency in initiation, a deficiency in proliferation result in failure of the tooth germ to develop and in less than the normal number of teeth happen. Excessive proliferation of the cell may result in epithelial rest. These rests may remain inactive or become activated as a later of irritation or stimulation. If the cell become partially differentiated or detached from the enamel organ in their particularly differentiated status, they assume the secondary function common to all epithelial cell and then will give us a cyst develop. So let's explain this in a different way. So you remember we discussed in a previous oral pathology chapter about the dentigerous cyst. And we said dentigerous cyst is coming from the remnant of epithelial rest. So this remnant is coming from this stage. So here, if the proliferation is arrested, so the tooth will be gone. And if proliferation is more, because now we speak about a one cap, if the proliferation is more, it will end up by epithelial rest remnant. This epithelial rest remnant will be detached from the enamel organ and it will stay at the side here. Enamel organ will continue to develop, give us a tooth, everything is fine. But this remnant, if it come to be activated later, it will end up by a cyst. If the cell become more fully differentiated, of this epithelial rest become more fully differentiated or detached from the enamel organ, they produce enamel undentin, which result in odontoma or supernumerary teeth. So again, supernumerary teeth can come from initiation or can come from proliferation. But odontoma and cyst is coming exclusively from which stage? Proliferation. Okay. Then moving toward, I told you before, if you remember, we have this invagination in this area. So this invagination means like different in proliferation of the cell, which will end up to this. So think about it this way. And then we have here will become this way. And it will become a totally different shape, which we are going to call a pill stage. The pill stage where all the action is going to happen. And this pill stage, we have early and late, which will end up by histodifferentiation, morphodifferentiation. So before I tell you anything, when I'm telling you histodifferentiation, so histodifferentiation, differentiation is differentiating between different cells. Histo is histological feature. So in this stage of histodifferentiation, the cell will be differentiating to become in a different histological shape, histological function. But in morphodifferentiation, the cell itself will become in different size and shape. So this is morphodifferentiation. So which is going to happen first? Histodifferentiation, because we have undifferentiated cell histologically be differentiated to be whatever, any enamel epithelium, outer enamel epithelium, whatever is going to be, and this will come in different shape, which is morphodifferentiation, to end up by formation of enamel dentin, cementum, and everything. Epithelium continue to invaginate and deepen until the enamel organ take on the shape of a pill. So this is what we call enamel organ, okay? And it come in the shape of a pill. Nice. The morphologic pattern or basic form and relative size of the future tooth is established by morphodifferentiation. Morpho is related to the shape. Morphodifferentiation, therefore, is impossible without proliferation. The advanced pill stage mark active histodifferentiation and an important stage of morphodifferentiation in the crown, outlining the future dentino dento-enamel junction. So this is the sophisticated English way, but the simple way. In the pill stage, we have early stage and we have late stage. In the early stage, histodifferentiation will start in the early stage. And then it will continue to start in the late stage. And in the late stage, we have exclusively the morphodifferentiation. So histo start from the early will continue in the late, and then morphodifferentiation is exclusively on the late. Why? Because there is no morpho without histodifferentiation to start with. It is during this stage that there is a differentiation of the cell of the dental papilla into odontoblast and of the cell of the inner enamel epithelium into ameloblast. So now we have enamel organ. So at this stage, which is pill stage, histoamorpho together, we are going to form odontoblast, ameloblast. So the question here, which one is going to be formed first? Think about this. So if I'm telling you ameloblast will give the first layer of enamel. So first layer of enamel will be resting over dentin, which didn't form yet. And if you start with dentin, so the nutrition or the process where enamel is going to form will be in the inside of the dentin. So we need a different mechanism or a unique mechanism for this induction. This mechanism, we call it reciprocal induction. So the mechanism of development of odontoblast and enameloblast to give us enamel and dentin is according to a theory which is called reciprocal induction. So let's discard the English now and see it in picture so you can understand it. So in this enamel organ, we have inner dental epithelium. So in this inner dental epithelium, we have cell here, and then we have cell free zone, and then we have cell reach zone. So this is how we start in the early pill stage. Then we are going to end up by odontoblast differentiating in the inside, and proximal end is coming from outside, which is going to give us ameloblast. And this ameloblast will give us enamel matrix, which is going to initiate dentin formation, and this dentin formation will go back to the pre-ameloblast to be differentiated into ameloblast to give us enamel. Yes, I think I lost you, so let's say it in a different way so for you to catch the information. So it starts by inner enamel epithelium. This inner enamel epithelium, in a different name, we call it pre-ameloblast. This pre-ameloblast is going to induce the outer layer of dental papilla, which is adjacent to it, which is in here. So we end up by this one, okay? This one, we call it inner enamel epithelium or pre-ameloblast. This one will give signal for the beneath it. So to give the first layer of here. Okay, so let's see it here. So pre-ameloblast, which is inner enamel epithelium, is going to induce the outer layer of dental papilla to give us odontoblast. This odontoblast will start dentinogenesis. This dentinogenesis will lay the first layer of dentin matrix. This dentin matrix immediately is going to give the signal back, is going to pay back for pre-ameloblast to differentiate it to ameloblast, which is going to give us enamel matrix. And the process goes on. Enamel matrix will go outside and dentin odontoblast will go inside. So we have enamel outside, dentin inside, and between both we have dentino-enamel junction. So out of this story, which layer is first to differentiate is the ameloblast, and which layer is first to deposit matrix is dentin, which is odontoblast. So you will read it and it will feel so confused because of this reciprocal induction. Reciprocal induction means pre-ameloblast, inner enamel epithelium signal the dental papilla to give odontoblast, which is going to lay down dentin matrix. So which one is going to be laid down first? Dentin. Which one is going to be differentiated first? Ameloblast. So I hope you understand the difference. Ameloblast and dentin is going to reciprocal induction. So I pay back you. So you end up by forming this way. So inner enamel epithelium giving signal for this one to give us dentin matrix. Then dentin matrix coming from the odontoblast. This dentin matrix immediately will give a signal for pre-ameloblast inner enamel epithelium to get as ameloblast to lay down enamel matrix. Yes, I invested a lot of time here, a lot of energy for you to understand it before we read it in English, because when you read it, you feel like it's so confusing. So differentiation of the dental papilla into odontoblast and inner enamel epithelium into ameloblast. Histodifferentiation marks the end of proliferative stage, as the cell lose their capacity to multiply. So at this stage, once we go to histodifferentiation, there is no multiplication. It's done. Whatever cell we have, this is the cell we are going to work with. This stage is the fourth runner, which means come before of appositional stage. Appositional, which is calcification. So there is no calcification without matrix. Disturbance in the differentiation of the formative cell of the tooth germ result in abnormal structure of the dentin or enamel. One clinical example of failure of ameloblast is Ameogenesis imperfecta, and of odontoblast is Dentinogenesis imperfecta. So Ameogenesis imperfecta, Dentinogenesis imperfecta happen at which stage? Pill stage. To be accurately specific, it will be in the early pill stage, which is histodifferentiation. Amazing. In morphodifferentiation stage, the formative cells are arranged to outline the form and the size of the tooth. This process occurs before the matrix deposition. The morphological pattern of the tooth becomes established when the inner enamel epithelium is arranged so the boundary between it and the odontoblast outline the future dentino-enamel junction. Disturbance and appreciations in the morphodifferentiation lead to abnormal form and size of the tooth. Resulting conditions include big shape and other microdontia and macrodontia. Stop here, take one step back, confirm the information. So we have pill stage. Histodifferentiation problem will lead to Ameogenesis imperfecta, Dentinogenesis imperfecta. Morphodifferentiation will lead to big shape lateral microdontia and macrodontia. Okay. And then the story goes more and more. For this event to take place normally, differentiating odontoblast must receive signal from differentiating ameloblast. And there is a simple logic about it. Ameloblast is going to give enamel. Without support of dentin matrix, this enamel matrix will fall down inside the dental papilla, inside the dental sac, will lead to like problem in the whole formative, in the whole creation of the tooth itself. So it must end up by dentin matrix first, but the signal come reciprocating coming from the pre-ameloblast and vice versa. So this is the reciprocal induction. Inner enamel epithelium cell continue their differentiation into ameloblast that produce organic matrix against the newly formed dentinal surface. So I hope this line, I spent the last few minutes trying to explain this line to be like, once you read it again when you study, please try to remember this to make sense for you. Almost immediately, this organic matrix mineralize and become the initial enamel layer of the crown. The enamel forming cell, which is ameloblast, move away from the dentin, leaving behind an ever increasing thickness of the enamel. So again here, ameloblast, this ameloblast, which is like this pre-ameloblast, which is inner enamel epithelium, will signal the odontoblast to give the dentin matrix. This dentin matrix immediately will give us signal back to the pre-ameloblast to be ameloblast to give us the enamel matrix. Okay, the odontoblast, as they differentiate, began to elaborate the organic matrix of dentin, which ultimately mineralize in the next few stages. As the organic matrix is deposited, the odontoblast move toward the center of the dental papilla, leaving behind a cytoplasmic extension around which dentin is formed. This is why tubular characteristics of dentin is established. Just this layer of dentin form, which is the mantle dental, differentiating inner enamel epithelium, which is ameloblast, secrete some enamel protein matrix, enamel protein, which do not accumulate as a layer. These first protein, together with other molecules, including growth factor, may play a role in epithelial mesenchymal signaling that lead to the terminal determination of odontoblast. So this is a different way to speak about the reciprocal induction. Changes also occur within the adjacent dental papilla, which is undifferentiated ectomesenchymal cell, increase rapidly in size to give us odontoblast. The increase in size of the papillary cell eliminate a cellular zone between the dental papilla and the inner enamel epithelium. So you're gonna tell me, okay, how come they confirm this theory? Now you're telling me about theory about pre-amyloblast sending signal to the odontoplast to give dentin matrix and all this. Tissue culture experiments have established that the differentiation of odontoplast from undifferentiated ectoms and camera cell of dental papilla is initiated by organizing influence from the cell of the inner enamel epithelium. In the absence of epithelial cell, which is inner enamel epithelium, no dentin develop. So they come to collect it and they remove this inner enamel epithelium from the dental papilla. So when they remove this one from dental papilla, this process didn't happen at all. So when this process didn't happen at all, they think about this reciprocal induction. The next step in the development of the tooth is thermal differentiation of ameloblast odontoplast formation of the two principal hard tissue of the tooth, which is dentin and enamel. So let's recap here again about it. So we have oral epithelium, dental lamina, and then we have this, which is the enamel organ. This enamel organ having this inner enamel epithelium, this inner enamel epithelium, as you see the long one, and the dental sac to be here, and the dental papilla to be just, dental papilla is immediately beneath the inner enamel epithelium, which is inside the enamel organ, and just beneath it we have what we call dental sac here, and this come later and to be very important when we go to the root development. Let's finish the dentin enamel of the crown. At this time, the enamel organ is two layers called named inner enamel epithelium, outer enamel epithelium. The inner enamel epithelium is next to the dental papilla with a basement membrane physically separating two cells. So here, inner enamel epithelium and this one. The inner enamel epithelium differentiate into ameloblast and produce enamel, while the outer enamel epithelium involved in the tooth eruption. So you're gonna tell me what's the function of the outer enamel epithelium, which is this part, Outer enamel epithelium is related to the eruption of the tooth. So outer enamel epithelium has nothing to do with the formation of enamel, has nothing to do with the formation of this reciprocal induction. So I would like to confirm this. Outer enamel epithelium involved only in the tooth eruption and form the junctional epithelium. So junctional epithelium is coming from remnant of the outer enamel epithelium, the bridge between the tooth surface and the oral mucosa. The two more distinct region of the ectoderm develop at this time. Stratum intermedia. So at this process, while this process done here, we have the signaling and inner enamel epithelium become ameloblast going up and odontoblast going down. At the same point, there is something happen here, inside here. This is the stratum intermedia. So here we call it stratum intermedia. Is one of the opposite side of the inner enamel epithelium from the dental papilla. So it's up, not down. These cells work with the inner enamel epithelium to form enamel. So why I keep repeating this? Because if I'm telling you which cell is working with inner enamel epithelium to form enamel, and in option you see outer enamel epithelium, no. Outer enamel epithelium is involved only in eruption ending up by junctional epithelium. So what's the other cell is the stratum intermedia. All, if you don't see it in the option, you're going to pick what? Stellate reticulum. Okay. Past the stratum intermedia are ectodermal cell called the stratum reticulum, which is like have this stratum reticulum, stratum intermedia, stellate reticulum. It has this star shape appearance, named for their star shaped rather than the cuboidal appearance of these cells. Okay. These cells help induce the inner enamel epithelium to differentiate and form enamel. So during this reciprocal induction, I told you about a step which we didn't specify, about other initiation which lead to this first signal coming from inner enamel epithelium, which we call it in a different scenario as the pre-ameloblast. This signal coming from which cell? Stellate reticulum, not from the outer enamel epithelium. These cells are found in the superficial but not the deeper region of the growing tooth germ. This accounts for the protection of enamel only on the crown or not on the root. So now we finish the story of the crown and dentin, and the crown, enamel and dentin. How about the root itself? So in root we have dentin, but we don't have enamel. In root we have dentin, but we don't have enamel. We have what we call cementum. Amazing. The leading edge of inner and outer enamel epithelium coming together, they call cervical loop. So inner enamel epithelium, like this one part. Inner inside, outer outside. This part is called what? Cervical loop. Let's give it different way. Here, this part is called cervical loop. Okay, question. In the cervical loop, do you see any stellate reticulum? No, because in cervical loop, it's cervical and loop. So in this area, as you can see here, there is little or no stellate reticulum. Nice. This is really important. They will explain why we don't have enamel on the root. As the cervical loop continue to grow around the dental papilla and extend deeper in the apical direction, we are going to give it a different name, which is Hertwig epithelial root sheath. The pattern of Hertwig epithelial root sheath growth determines the shape of the root. So now we have this one coming down, which is going to give us the shape of the root. So we have teeth with one root, and we have teeth with multiple root. So how does this Hertwig epithelial root sheath is going to extend apically, or is going to stop at certain point, increase in length, and certain point it will end up by root, different root. And this differentiation will give us more than one root. And the length and the root tract is coming because of the differentiating length or differentiating growth of the Hertwig epithelial root sheath. Hertz, which is Hertwig epithelial root sheath, does not grow evenly around the dental papilla of larger teeth. Instead, this grows faster in some region as extend over the dental papilla. Perhaps the way chocolate fudge drip over a bowl of ice cream unevenly. On a larger teeth, this produce multiple root. So this one, like, let me give you a picture here. Okay, so this one will go down, 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 down. At a certain point, it will stop. At the buccal side, it will go more down. At the lingual side, it will stop. At the mesial side, it will go more down. So this will give us the appearance of like this. You have the ice cream, which have this chocolate over it. So this chocolate coming from here and stopping here. So this will give us finally the appearance of multiple root. Okay, so we discussed now about the root itself. So let's discuss now about the problem of no enamel over the root. Hertwig epithelial root sheaths contain inner and outer enamel epithelium and no stellate reticulum. So if you remember, we said this is stellate reticulum with the inner enamel epithelium will give us to be pre-amenoplast, and this reciprocal induction to give us the amenoplast, which lead to the key differentiation between crown and root development. The inner enamel epithelium induce formation of odontoplast in the root just as it did in the crown. But when odontoplast from predentin, they give the signal back to stellate reticulum, they don't see stellate reticulum. Mean differentiation of amenoplast does not occur in this area. Hence, root do not contain enamel. And this is why enamel pearl stuff like this is because of the problem with this Hertwig epithelial root sheath to be not very effective in this area, and this will lead to enamel pearl or cervical extension. And instead, most of inner enamel epithelium, outer enamel epithelium cell undergo apoptosis. A few are left behind, which get the name of epithelial rest of Malazes, and this will give rise for some cysts. I hope you still remember the cysts from oral pathology. These leftover cells might have function in regeneration of damaged root tissue, although this is not currently well understood. After the majority of the epithelial cells are removed, neuromesenchymal stem cells of the dental sac contact predentin, contact which predentin, as this induced them to differentiate into cementoplast. So cementoplast coming from dental sac, coming from neuromesenchymal origin. These cells cover the root dentin in a relatively thin layer of what we call cementum. Some region of cementum contains cementoplast, this is called cellular, and some does not contain, which we are going to call acellular cementum. So if you're feeling lost now, so let's finish the last two stages, and then I will give you in simple term about each one. So here, some diagram, some numbers, location, so you understand this inner, outer, cervical lobe, stellate reticulum, and how it does to have no enamel over the root. Finally, now we have matrix. Now we need to do apposition, mean the calcification to start. So after appositional growth is the result of a layer-like deposition of a non-vital extracellular secretion in the form of tissue matrix. This is the appositional. The matrix is deposited by the formative cell of ameloblast odontoblast, which line up along the future dentino-enamel and dentino-cemental junction at the stage of morphodifferentiation. These cells deposit the enamel and dentin matrix according to the definitive pattern and at a definitive rate. The formative cell begin their work at a specific sites that are preferred to growth center and soon the blueprint the dentino-enamel junction. Any systemic disturbance or local trauma that injures the ameloblast during enamel formation can cause interruption or an arrest in the matrix apposition, which result in enamel hypoplasia. So why enamel hypoplasia is not happening as we discussed about the embryonic imperfecta? Because enamel hypoplasia usually have to be specific for a specific tooth, which we call it in a different name, Turner's tooth. So this happened for a specific tooth while it go through apposition. And this is why you are going to see when you discuss an oral pathology, the main etiology of it, infection of the primary tooth. So the infection will come close to the tooth germ of permanent one, which will disturb this apposition, leading to enamel hypoplasia. Hypoplasia of dentin is this common and needs severe systemic disturbance to lead to calcification. Now we have matrix. So calcification take place following the matrix deposition and involve the precipitation of inorganic calcium salt within the deposited matrix. The process begins the precipitation of a small nidus about which further precipitation occur. The original nidus increase in size by addition of concentration lamination. So if you remember this rings we discussed trias of Red Sea, I hope you still remember it from the restorative one. There is an eventual approximation and fusion of this individual clastropheres into homogeneous mineralized layer of tissue matrix. If the calcification process is disturbed at this point, there is a lack of fusion of this one. This deficiency are not readily identified in the enamel, but in dentin they can evident microscopically and referred as interglobular dentin. So if a problem happening in this stage, it will lead to interglobular dentin. Quick recap about it. So problem with apposition leading to amazing enamel hypoplasia. Problem in calcification leading to interglobular dentin. Why this is not happening in the other way? Because yes, it can have some hypoplasia of enamel dentin, but this require systemic condition. Okay, so let's recap everything and get the few slides. At this point, maybe you skip the previous part, no problem with me, but at least try to listen to it. If you did listen to it, thank you to finish till the end. So now it will pay off when I'm telling you the stage, what's happened, what's the problem. This is the part you need to memorize. Initiation happened in 6-week intrauterine. 6-week intrauterine. Oral epithelium will give us the outer layer. Dental lamina, which is the first evidence of forming budding of the tooth, happening at which week? 6-week intrauterine. Ectomesenchyme signaling over layer oral epithelium to proliferate into dental lamina. So this initiation will give us a signal for this ectomesenchyme to give us the dental lamina. Moving from 6 weeks to 9 weeks. Before we move, if we have a problem here, it will lead to no initiation, which will lead to congenitally missing teeth, or super initiation, more than one signal coming to the oral epithelium, which will give us supernumerary teeth. In cap stage, because of this proliferation happening here, it will end up by a cap. This happened 9-week uterine. Dental placido, which is proliferating bud. All primary teeth and permanent molar arise from dental lamina. Permanent incisor canine and premolar arise from their primary predecessor. So starting from 1 till 5, we have primary teeth, which A, B, C, D, E will be replaced, and then go, and then come the permanent one. But the primary teeth and permanent teeth all coming from dental lamina. So we have successive lamina, which is coming from the previous primary teeth, or we have lamina with tooth bud coming by itself, which is 6, 7, and 8, because they don't have primary predecessor. And then the condensing mesenchyme start to happen in this way. Okay, so we act ectomesenchyme and then condense ectomesenchyme. Nice. In this cap stage, 9-week intrauterine, problem happen, congenitally missing, or supernumerary teeth. Moving forward to bud stage, we said the proliferation here start to get this invagination here, which will form the enamel organ. This happened in 8-week interuterine. This enamel organ will give us enamel, as the name implies. Outer enamel epithelium will give us amazing junction epithelium, which is related to tooth eruption. Inner enamel epithelium with the stellate reticulum, both together, will give us what we call reciprocal induction. Both will be responsible for differentiation of inner enamel epithelium to ameloblast and then giving the enamel. And the enamel shape will happen in this stage to give us enamel knot, which happen to be the cusp tip. And then on the other side, in this area, in dental papilla, we have a totally different mechanism of dental papilla to give us dentin and pulp. And finally, we have dental follicle, which come in action later, where it gives us the cementum. Error in the bud stage will lead to cyst, odontoma, gemination, fusion, or dense indent. This is related to the formation of the teeth itself. Moving forward to explain more about the pill stage. So now, after having this bud stage, it will give us the pill stage. So in pill stage, we have well-formed enamel organ. This happened in 2 stages. The pill stage itself has early pill stage and late pill stage. And we said histo and morpho. And we said morpho is the shape. Shape cannot happen without the differentiation of the cell, which is histo differentiation. Histo differentiation in early will lead to inner enamel epithelium to give ameloblast and dental papilla to give odontoblast. I will not say about the mechanism of reciprocal induction. I know now you know by your heart. Defect in this problem, defect in this early pill stage will give us ameogenes imperfecta or dentigenes imperfecta. I know it's annoying, but sometimes you see the question in this depth. Histo differentiation, early pill stage, ameogenesis, dentigenes imperfecta. Late pill stage, which is related to shape, size. If a problem happen here, it will lead to big shape lateral and macrodontia. Finally, we have apposition. Now we have odontoblast, ameloblast is working to give us the matrix. How about the matrix coming in here? Odontoblast deposit dentin matrix, ameloblast deposit enamel matrix, amelogenin, and then ending up by cervical loop. This cervical loop will end up by Hertwig epithelial root sheath, which has no stellate reticulum. No stellate reticulum with inner enamel epithelium means no enamel, mean dentin will be here. This dentin come in contact with the sac will give us cementoblast, which will give us the cementum covering it. And this epithelial rest will give us epithelial rest of molasses and the inner and outer enamel epithelium, which will give us at the end the junctional epithelium. Defect here will lead to enamel hypoplasia, enamel pearl, or cancerosis. Why this happened? This happened due to some stellate reticulum coming at the end of cervical loop, which work with inner enamel epithelium to give us enamel. Usually, we don't have this problem. Okay, and this diagram will explain everything. If you feel lost, you just look here, and I think you will catch it. But I believe at this point you understand what's the meaning of early and late pill stage or advanced pill stage, and why histo happened before morpho differentiation. Finally, we have maturation, which happened in 14 weeks and above. This is the calcification. Begin at the cusp tip and saddle edge and then go forward. It takes 2 years for primary teeth, take 4 to 5 years in permanent teeth. Problem in this area will lead to enamel hypermineralization, fluorosis, tetracycline staining. If you remember this one, we discussed about maturation. Finally, we have this problem. We have this one. Enamel organ giving ameloblast, which is give enamel. Dental papilla, odontoblast, dentin. Central cells will give us a pulp. Dental follicle, cementoblast, cementum. Osteoblast, alveolar bone, fibroblast, PDL. So this is the origin of each cell. So dentin coming from dental papilla, alveolar bone coming from follicle, enamel coming from enamel organ, enamel coming from enamel organ, which is coming from ectoderm. Dental papilla giving dentin. Dentin is coming from dental papilla, which is coming from ectomesenchyme, which is neural ectomesenchyme. And dental follicle, dental papilla, both coming from neural ectomesenchyme. And this is a different way to speak about ectomesenchyme and the neural ectomesenchyme. Okay? I know this is too much. Please, if you feel confused, Ask me in the live session, ask me one-to-one, but this part is important, and the information in the last 2 slides is the information you need to memorize. I hope at least you watch the story once so you can catch the problem. Okay, so let's discuss now about the difference between primary and permanent teeth. So the crown of primary teeth looks wider, mesiodistal. The roots is narrower and longer. The roots also relatively longer and more slender than the primary teeth, the permanent teeth, and it has this flaring. Like if you extract any primary teeth, you will see the flaring. Let me give you a picture. This one, this flaring. Why this flaring here is really important. You see the trunk is short, the roots are longer and cylinder more to give a space for permanent tooth to come in here, okay? To give a space for the permanent tooth, but the cervical ridge of the enamel at the cervical third of anterior crown is much more prominent labially and lingually, and this is very important for us when you are going to do the stylus C crown because of the constriction. The constriction at the cemento enamel junction is very huge. There's huge constriction. The crown and the root of primary molar more cylinder mesiodistally. The cervical ridge on the buccal aspect of primary molar is much more defined. The buccal and lingual surface of primary molar are flatter above the cervical curvature than those of the permanent molar, which make occlusal surface narrower compared to the permanent teeth. The primary teeth are usually lighter in color than the permanent teeth. So you see here, it's wider mesiodistal. Huge constriction here, and the roots are cylinder and longer. You see here specifically the lower canine have this very prominent cusp, and it's wider mesiodistal. Okay. So apart from this, sometimes ask you specific question about specific teeth. Maxillary center incisors greater mesiodistal than cervical incisor. Maxillary canine has sharp cusp and long cylinder root. Mandibular center incisors straight incisal edge and root twice the length of the crown. Maxillary first molar, here we discuss all about the primary teeth. Maxillary first molar have large mesiolingual cusp and 3 long cylinder roots. Mandibular first molar has 2 distinct buccal cusp and prominent lingual conversion. Mandibular second molar resemble the first permanent molar. Mandibular second molar resemble the first permanent molar. And this is weird information, sometimes you will be asked about. Finally, the primary second molar has long cylinder root with mesiodistal flare in the middle and apical third. Okay, will you ask me, should I memorize all this? No, I don't like you to memorize all this, but I would like you at least to know the information here in this part. The previous part is giving us like, yeah, this is all the difference between the teeth. But here giving us a specific difference between the specific teeth. So yes, you should memorize at least this part. Finally, table of the teeth eruption. You should know it. You should memorize it. Specifically central and the permanent first molar. The central and the permanent first molar. In the live session, I'm going to give you some tables or some way that you can easily try to memorize the most important parts. But there is some rules. I'm going to tell you more about it when we go to the live session. Yes, I know this lecture is not the first, it's not a very appealing start of the pedodontics chapters, but trust me, this is I tried to collect all the dark information from the pedo to be coming in one chapter. So you have the shock at the beginning and then later on it will become easier. Promise, it will become easier. Thank you and watch you and see you in the second lecture, which discuss about the cavity preparation for the primary teeth.